The first company, it's Reverigen, and with my pleasure to introduce Eric Hoffman.
So I'm going to show you how steroids work in Duchenne. So in Duchenne, you have myofiber dystrophin deficiency. That causes membrane instability, which you've heard about. And what we've shown is that as soon as the child is, soon after birth, not in fetal life, but as soon as the child's born with Duchenne, you start what's called danger signals, or what's activation of what's called innate immunity, or NF-kappa B. And that then goes into the cells of the muscle and turns on a pro-inflammatory state. So the muscle is already quite upset and pro-inflammatory soon after birth. And that inflammation also feeds back and exacerbates muscle damage. So inflammation itself sort of worsens dystrophin deficiency. So this process is present in DMD muscle from birth, shared with many chronic inflammatory states. So asthma, arthritis, all share this same process. Lupus, multiple sclerosis. And that's the target of corticosteroids. Glucocorticoids or corticosteroids like prednisone and deflazacort are used in all these disorders to suppress this NF-kappa B. Now how that works is the steroid, so there I'm just showing prednisone, comes in and binds what's called a receptor, a glucocorticoid receptor. It's the same receptor we all have that wakes us up in the morning with cortisol goes up and wakes us up about 4 a.m. And whenever we're stressed, you hear about stress hormones, that's the same hormone. And it's basically the same as prednisone and deflazacort. So that's one thing that's already been remarkable is your day-night hormone is the same as your stress hormone, is the same as your anti-inflammatory drug, which is prednisone and deflazacort. So once that binds, it's very clear now that that goes into the nucleus and punts off these NF-kappa B. There's a great paper out of Emory recently that says these monomers, a single receptor with a drug bound to it, goes in and actually stops inflammation at that DNA level. And so that cuts down on inflammation then, and that inhibits inflammation, lessens myofiber damage, improves symptoms, and as you all know, glucocorticoids do work in Duchenne. Now, that's the beneficial effects. Actually, what most physicians and students have learned in school is not a monomeric form, but what's called a dimeric form, two of the receptors and drugs together. That they form this complex, go in and bind a whole different set of pieces of DNA, much more pervasive pieces, many pieces in the genome, and that increasingly is recognized as side effects. So what you see here, and what our goal was, is if the efficacy is through these single units, and the side effects are through the double units, can we make a drug that only does the single and not the double? And so that's the goal of the vamorolone program. So here's the structure, actually what it looks like in solution X-ray structure of vamorolone superimposed on prednisone. So prednisone is blue, vamorolone is red, and you see they're very similar drugs. We've just put a kink in that one area of vamorolone, and that ends up causing this ability to bind as a monomer, but not as a dimer. And so that ends up as this disassociation of efficacy and side effects. Now, we did add a couple other features besides this disassociation. As we developed the drug, it turns out, you've heard it a number of times in this meeting about eplerenone and spironolactone that are cardiac failure drugs and have been shown to show efficacy in Duchenne muscular dystrophy. Well, we ended up making eplerenone, a version of eplerenone. So that's quite the opposite of prednisone and deflazacort. Prednisone actually binds to the mineralocorticoid receptor as an agonist. It turns it on. Eplerenone turns off the mineralocorticoid receptor, and that's what we do as well. So we've really separated out a different type of function from both prednisone and deflazacort as well. We also import better membrane stability, and I mentioned the side effects. So this is the trial I'll show. This is a phase 2A study that recently completed the 2A extension. So as you see, patients were enrolled in what's called a phase 2A, or multiple ascending dose, which was 2 weeks on drug and 2 weeks off drug, and then enrolled into a 6-month or 24-week long-term extension called VBP003. And then once they finish that 6 months, they can enroll into a 2-year long-term extension where they can escalate dose. So the first 2 periods were on one of 4 doses. It was a broad dose range going from 0.25 to 6.0, which is about 24-fold dose range. Prednisone is typically prescribed that 0.75 and deflazacort similarly, a little higher. So we really went from 1/3 prednisone or deflazacort dose to 10 times deflazacort or prednisone dose. There were 12 kids per each dose group, and these kids were steroid naive coming into the trial. Once you're on the long-term extension, all the patients have escalated. And there's been very good retention of all the patients into the long-term extension. Of the 48 patients enrolled in this trial, 46 are on the long-term extension and all have dose escalated to the higher doses. These were 4 to 7-year-old kids never taking steroids and 12 boys per group, so 48 total. So this was the investigators, Paula Clemens, who you heard from earlier with the NS Pharma trial. Nixon Skipping was also the study chair of this trial. ReVirogen was the sponsor. TRINS and the Cooperative International Neuromuscular Research Group coordinated this study along Andrea Smith. And we had 2 external comparators. The Synergy Group, CI-NRG, or Cooperative International Neuromuscular Research Group, is a clinical trial network that's long-standing in Duchenne. We've enrolled 1,500 kids into different studies. And so we had the big natural history study called Synergy DNHS. 440 kids followed long-term, Craig McDonald study, Eric Nixon. That's done by the Synergy Group, and we also did a prednisone trial some years ago. Deanna Escolar was PI. So we had these external comparators of previous studies done by the same sites, same evaluators that we could compare to. Okay, the first thing I want to show, which was interesting, I think, to many in the audience, is that we designed the trial to actually have quite a few measurements of time function tests early in the trial. So within 6 weeks, around 6 weeks, we had 4 different measurements of each of these tests in each child. So 48 children, 4 measurements within 6 weeks. Well, when you have as many as 4 measurements, you can do a classic measure of reliability or precision, which is called a percentage CV. You just take the standard deviation, divide it by the mean, and the FDA has established criteria for precision. So a laboratory test like measuring dystrophin, you should have your percentage CV below 25%, and it's a good test. And what we see is, as much as myself and others complain about 6-minute walk tests, it is an amazing CV. The kids were in this 4 to 7-year age range were remarkably reliable. The time to 10 meters run walk was reliable. Northstar was quite reliable. Others start to fall off. Now, in this trial, you have to pick your primary and your secondary outcomes. So we talk to parents. We involve parents all throughout the trial design, keep the visits down, both in Europe and the US. And we ask parents of these different outcome measures, which is most important to your quality of life. And they all agreed that time to stand. The visualization is falling in a street or at school, having trouble getting up. And so we chose that as our primary outcome. But if you notice, the reliability isn't so great. Okay, and it takes a while for a kid to interpret getting up, particularly in this young age range. But why I also dwell on this a little bit is you'll see the subsequent p-values. So I'll show you p-values statistics between these different treatment groups. They directly correlate with precision. So in other words, the more precise your outcome measure is, the better your p-value gets. And I hope that should make sense to all of you here, because if a kid is reliable and that test is reliable, meaning that every time you test that one kid on that one test, you get the same answer, it's easy to see a drug effect, and you get good statistics. But if the kid has a different measurement day 1, day 2, day 3, day 4 that's all over the place, either because of attention or age or weakness or focus or whatever, then it's hard to see a drug effect because there's too much variability in the measures to see if the drug's working. Okay, so we'll start with the time to stand. This was our primary outcome. So all the graphs, whoops, now I have to go back. All the graphs will look similarly where there's 4 dose groups. The lowest dose group is the lightest blue color in the bottom, 0.25. The next dose group is 0.75. The next is 2.0 and 6.0. So 6.0 is the heavy line. So one thing you see, and all these graphs will show you baseline at 3 months or at 12 weeks and 24 weeks of treatment. And so what you see is the 2 lower dose groups either decline slightly or stay the same, but the 2 high dose groups show an improvement in time to stand velocity, which means they're much quicker. They're quicker at standing up. And when you run statistics just within the trial, you see that's statistically significant. Remember, there's only about 11 or 12 kids per dose group, so you can see it's a fairly good effect size, but in an outcome measure that's not entirely reliable. We can then superimpose the Duchenne natural history study that Craig McDonald and Eric Henriksen and many in this room have worked with. And you see that the natural history study, which is steroid naive, 4 to 7-year-old kids, so matches pretty well with the lowest dose groups. And it's also significant relative to the high dose groups. So at least we met our primary outcome as far as improvements of time to stand. So now we'll go to secondary outcomes. And so this is your 10-meter run walk. And so what you see is the natural history study, again, is sort of low, declining slightly, and matching with the low dose groups. But you see these improvements in speed of the higher dose groups. And if you just compare the 25 patients in the natural history study versus the 11 with vamorolone high dose, you see a p-value of 0.003, which is really strong. Okay, so this is very strong significance. And a key thing through all these studies is we'll always look at dose response. Dose response is a really critical thing. The FDA and EMA really like dose response because, as you can see, it's more compelling. If you see a low dose doesn't do much, and as you ratchet up the dose, it does better and better, that looks convincing, right? It's not going all over the place. And so this is a very clear dose response in each of these slides. Then 6-minute walk, we didn't have the external comparator, but here you see over the 6 months, the lowest dose declines a bit, loses 10 meters, but you see the highest dose gains 45 meters on average. And again, a very clear dose response. And they're very highly significant. Northstar assessment was a reliable outcome, but it turns out it's not good in this trial because it has a lot of developmental component to it. It's all these combined Sierra Carnation shaking his head in agreement. With all these scales and asking the kid to do so many things, as they're getting older in this young age range, they're improving anyway, right? And so with that, you see the 2 lowest dose groups are actually improving. That's not because of the drug, that's because they're just developing. Well, the problem is that kills your statistics when you're looking at a drug effect because everything's improving. So even though it looks like the drug's having a good effect, which it probably is by all the other data, it's not statistically significant. Okay, then we looked at biomarkers. So one was, you've heard about today, was serum creatine kinase. And you see it, each of the 4 dose groups there in the corner. Does this work as a pointer? Probably not, right? 0.25, 7.52, and 6. And you see the variability in CKs. This is just after 2 weeks on drug and 4 weeks later, which is 2 weeks off drug. And what you see is the 2 highest dose groups actually decrease CK significantly. And it's interesting, even after we withdraw the drug, the CK keeps declining, which implies the membrane stability and anti-inflammatory effect. So about a 30% drop in CK. Then we had a series of steroid-responsive biomarkers. So these are, we just take a small blood sample from the children, and then we run what we've defined as 7 different proteins floating around in all our blood, that if you have a chronic inflammatory state, they go really high. And we looked at Duchenne, we looked at pediatric inflammatory bowel disease, juvenile dermatomyositis, and adult vasculitis. All these are chronic inflammatory states treated by steroids, glucocorticoids. And in each of those cases, when you give the patient glucocorticoids, those inflammatory proteins go down. So they're corticosteroid responsive inflammatory biomarkers in the blood, which means we can see the action of the drug in the blood by just looking at these steroid-responsive biomarkers. Okay, so we pre-specified these in the trial, and then we studied these in this vamorolone trial, and that's just 2 examples in the bottom. The red line is the lowest dose at baseline and 2 weeks later, and then it just goes by increasing dose. And so it's very clear as you increase the dose, these inflammatory proteins go down, 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 down. Again, a clear dose response. It's quite compelling, and it's statistically significant. So it says the drug's hitting its anti-inflammatory target, and you're seeing, again, a clear dose response that makes it compelling. The key thing here is, so we want to keep the efficacy of prednisone and deflazacort, but we want to lose the side effects. That's the point of this program. So in adult volunteers, we went quite high to 20 mg per kg, and we stopped there, but it was still safe to that dose. And again, that's about 30 or 40 times what a Duchenne kid is usually given in either deflazacort or prednisone. In the phase 2A, we went up, as I mentioned, to about 6 mg per kg or 10 times prednisone dose. And again, there was no problems, no safety signals that would preclude even going higher. As far as all the safety data, adverse events, you've seen that in other presentations, but that's still under analysis, but nothing of concern that seems to be clearly drug-related. So going to the prednisone side effects and deflazacort side effects, we recently, and some of you might have participated in this, out of Binghamton University, we did a quick internet survey of all the side effects of deflazacort and prednisone and asked you as parents to sort of rank what you were most concerned with. And so this was the first 50 respondents. It was mostly in the UK, US, and Canada. And loss of bone density is the biggest one. So about 80–85% are very concerned about bone side effects. Weight gain is 75% very concerned, and tied for number 3 with about 50% very concerned were stunting of growth, delayed puberty, suppressed immunity. Things like adrenal crisis or cataracts or mood disturbances weren't that important to the parents. So these, many of the other side effects didn't seem to be so important. So let's look at those. So how do we look at these side effects? Well, for bone, obviously you can look at the frequency of bone breaks or the stunting of growth, but that takes years, right? Many years of treatment to really look at that. Well, what they do in other clinical trials with steroids, in fact, with arthritis and other diseases, is look at what's called bone biomarkers. So osteocalcin is a protein we all have. It comes from bone, and when bone is building itself and growing, it puts more osteocalcin into your bloodstream. So the amount of osteocalcin you see is a marker of bone formation. What happens when you give any child with any glucocorticoid, deflazacort or prednisone or anything, or any adult, osteocalcin just tanks. So osteocalcin goes very quickly, even within hours, down of the first dose, and it stays down. And so that's the loss of bone formation that's so characteristic of glucocorticoids. So when we look at the phase 1 data, all the way up to 30 times prednisone dose, no changes of osteocalcin. And when we look at these Duchenne kids, no changes of osteocalcin. So basically, our bone formation, even at much higher doses than prednisone or deflazacort, is keeping constant. And that agrees with our preclinical data where we didn't see any bone changes in mice, we didn't see any stunting of growth, we didn't see the bone side effects. And so this suggests we've lost the bone side effects with vamorolone, even going to 10 times prednisone dose or higher. Insulin resistance, that's why glucocorticoids are called glucocorticoids, is because they have very profound effect on glucose metabolism, which is called insulin resistance. And we see no changes in any adults up to very high doses, whereas again, with a very low dose of prednisone within hours, you've changed, or deflazacort, you've changed insulin resistance. In the Duchenne kids, we see a slight uptick of insulin, very hardly significant. Glucose and HB1AC, which is looking at insulin resistance, don't change. So it seems we've largely, if not completely, lost insulin resistance. Adrenal suppression, it's not listed as a concern of parents, but it is a clinical concern because of risk for adrenal crisis. And many of you, if your children are on or prednisone or deflazacort, you might have a card. And the card says that if I get into an accident or ill, make sure you give me replacement corticosteroids. That's due to adrenal crisis. So it's not present and obvious, but it can be really bad. I mean, you can die from that. So we show much less adrenal suppression. It's variable. When we go up to 30 times prednisone dose in adults, it's 100. Everybody shows adrenal suppression. But in the Duchenne kids there at the bottom, it was of the 2 efficacious doses that were showing clinical improvement, 1 out of 6 kids at 2 mg per kg, and about half the kids at the highest dose, 6 mg per kg. What about weight change? So here I'm showing patient-level data. And so this is, each line is an individual patient in this trial, and I've separated it by the 4 dose groups. And you can pretty much see just by the slide, when you start getting to the higher dose groups, some kids are showing weight gain. Okay, this is BMI, so body mass index. So at 6 mg per kg, well, at 2 mg per kg, it seems really only 1 kid showing weight gain, one of the boys. But by the time you get to 6, it looks like 3 or 4 are showing weight gain. So in the next slide, I just compared this to prednisone. So prednisone, it shows weight gain, But if you notice here, this is the prednisone synergy trial. It's also variable, at least at 6 months treatment, where one kid is showing an amazing amount of weight gain, but others aren't showing any, and some in between. And so really, at that point, at 10 times the dose, so we're looking at, if you compare vamorolone 6 mg per kg to prednisone 0.75 mg per kg, about a 10-fold difference, you're seeing similar amounts of weight gain, but it's variable. Okay, so the conclusions are we're seeing clear benefit or efficacy, all the time function tests. Time to climb stairs was also significant at both 2 and 6 mg per kg. The pharmacodynamic biomarkers were clearly improved relative to prednisone and deflazacort. We see this decrease in creatine kinase levels, and we see improved safety relative to published studies of prednisone and deflazacort, both in phase 1 and phase 2 studies. So our next step is to go to phase 2B, or it's really a phase 3 study, and we're taking those next 2 doses, and we're starting to enroll this week, or next week, this month. Study chairs are Michaela Guglieri and Paula Clemens, again, who you've heard from earlier, and again, Trins and the Synergy group are doing this. This design has a blinded first period for 6 months. 50% of the DMD boys go on to vamorolone at one of the 2 doses, 25% placebo, 25% prednisone. After 6 months, the placebo and prednisone crosses over to vamorolone. So it's just 6 months on placebo or prednisone, then you cross over to vamorolone. 120 boys, or 30 per dose group, 4 to 7 years not previously treated with steroids. And again, we've tried to reduce the visits and make this not very burdensome. I should mention all dosing is done at home. It's just an oral suspension, just taken with a glass of milk every morning. It's no injection or anything. And the info on clinicaltrials.gov is there. And the blue sites are the ones that enrolled into the phase 2A and also are joining the phase 2B. And then the new sites into the next coming trial are also listed there. We've added Seattle, Colorado, Richmond, and then 3 additional sites in Canada. And then these are the international sites so far. Newcastle and Israel and Australia and Sweden were in the phase 2A, and then we've added additional UK sites, additional Swedish site. So I went over these slides with foundations that had supported the program, and I acknowledge them in the next slide, over the last week, and we had a press release coming out this last week. And some persistent questions came up, so I thought I'd anticipate those in this one slide. When will trials of older and younger DMD patients be carried out? The EMA requires a PIP, a pediatric investigation plan, so we have trials planned from newborns through 18 years, both steroid-treated and not steroid-treated. The next anticipated trial is supposed to start next summer, which will enroll both 2 to 4-year-olds and 7 to 18-year-olds. Those would be in this trial steroid naive again. Why the 3-fold jump from 2.0 to 6.0? Why not try an intermediate dose or higher than 6? And you've heard from other speakers, this whole therapeutic index, finding the right dose, is really, it's complicated. There's a lot of issues, both side effects and efficacy and discussions with regulators, et cetera. We felt that 3-fold was aggressive but appropriate. Regulators often accuse programs of not going high enough, and it's all a balance, and at the end of the day, patients are individuals and doses may need to be optimized. And finally, this whole program was done completely in collaboration with foundations and governments. So this is run under what's called a venture philanthropy model, so there's no private stockholders. Or VCs, venture capitalists, and all these foundations were instrumental in not only providing funding, but also peer review, giving feedback on the program, and help with the design of the clinical trials. That's it, thanks.